like, share, and subscribe here on Oncology Tube to get notifications when similar videos are available.
Okay, so my name is Dalia. I'm one of the first-year fellows at UCI. Just quick thank you to Dr. Zell, also to Moask, for having me here. The topic of today's presentation is irAEs, so immune-related adverse events in patients with solid tumors and advanced CKD, which I'll define later, but we include CKD3 through ESRD, receiving checkpoint inhibitors. And I'll be presenting, as Dr. Zell mentioned, just kind of a brief overview of our project, which was presented via poster at ASCO. So I also want to thank my co-fellows that helped me out with this project and our attendings as well. So thank you to Elham, Brian, Omid, Dr. Mar, Dr. Azazadeh, and Dr. Valoran. I have no disclosures. So just a quick background. As many of you may know, clinical trials traditionally, when they evaluate CPIs in the management of solid tumors, have generally excluded patients with CKD4 and ESRD, and some have included those with CKD3. So that's kind of why we had an interest in this topic, as these patients were traditionally excluded but could also potentially benefit from these therapies. So there is limited data evaluating the safety of CPI use in this patient population. And the limited data is mostly along the lines of case reports, case series, and those limited cases do suggest a similar incidence and types of irAEs in patients with advanced CKD and ESRD when compared to patients with normal or mildly impaired renal function. So CPIs are not modified by dialysis due to their molecular size and do not require renal dosing due to the size of the monoclonal antibodies. So here I just kind of summarize a great analysis review that consolidated all the case reports and case series on the topic of ESRD patients on HD with solid tumor malignancies on checkpoint inhibitors. So in all the literature, this report by Kitchlew et al. Finds about 98 patients in total. There you can see kind of a summary. So about a third had RCC, urothelial, 23 patients out of the 98, melanoma 16, lung 6. The most commonly used immune checkpoint inhibitor was nivolumab at 38, followed by pembro and then atezolizumab. So there were a total of 48 irAEs, 33 of which were grade 1 and 2, and 15 of which were grade 3 and 4. So that's about, some patients, it's not really fleshed out in the report, but some patients do have more than one irAE, but you could just consider this averaging about 50% of the patients did have an irAE. And then here you see how common each irAE was. So number one they had was hematologic, followed by dermatologic, pneumonitis, endocrine, hepatitis, GI diarrhea, and so on. So this is kind of a summary, so I want you to kind of keep this in mind, and I'll present kind of what we found as well. And I will say that we actually have a larger retrospective study that we conducted at UCI with about 450 patients looking at irAEs on patients in checkpoint inhibitors and solid tumors. So I'll kind of go through and give a brief comparison of what we find in our ESRD and CKD patients with what we found kind of overall. So just briefly here are the methods. So retrospective analysis, patients 18 and over, solid tumors, we included GI, GU, lung, head and neck. They had advanced CKD. They received CPIs at UCI over about a 6-year time span, 2015 to 2021. Advanced CKD was defined as GFR less than 60. So CKD3, GFR 30 to 59, CKD4, GFR 15 to 29, CKD5 ESRD less than 15. I think ideally we would have liked to just do a study on CKD5 and ESRD, but as you'll see that there's kind of a limited number of patients that would fall into this category. And then they must have received at least one dose of a PD-1 or PD-L1 or CTLA-4 inhibitor, either as a single agent or in combination with another therapy. So here are the results. There's a total of 32 patients that were included. You can see the patient race on the left of the screen. So about 2/3 of them were Caucasian or white, followed by Asian, Hispanic, one Black, one other. Median age 73.5. The range was pretty wide, 26 to 98. About 1/3 were female and 2/3 were male. And then here in the top left, we have therapy type. So CPI only is in the blue. It's about 2/3 of the patients, and CPI plus other was about 1/3, 10 patients out of the 32. Was there an irAE? Very even split, about 50%. So if you remember from the earlier slide, there was about 50% also in that larger study. And then in our bigger study with the 450 or so patients, we actually have about a 50% rate of irAEs at UCI through, we use the same methods to account for those. And then CKD stage of the patient, there were 2 with ESRD, 6 with CKD4, and 24, so 75% with CKD3. Percent of patients in each group who developed irAEs. So keep in mind, we only had 2 patients in this CKD5 ESRD category. So these are in the CKD3, there were 58% of those patients that had an irAE, CKD4, 33%, and none of the CKD5 ESRD patients had an irAE. And then here you can see the distribution of the different irAE types. So from bottom to top, we have colitis and diarrhea as the top one with 6 irAEs reported of this type, followed by dermatologic and endocrinopathy at 4, arthritis and renal at 2, and then all the others that you'll see there is 1. So many people think about, do patients with CKD have a higher risk of renal-related irAEs? Just thinking about the role of T cells in AKI and recovery, but actually, no, we did not find that. Also, interesting to note, our top 3 irAEs, colitis, dermatologic, and endocrinopathy, are actually the same top 3 irAEs we found in our larger study as well. So those are the top 3 listed there by percentage. 78.3% of irAEs were grades 1 and 2, which I think it was about 75% in that review that I discussed from earlier, and 21.7 were grades 3 to 5. So just some conclusions, key takeaways. So as I mentioned before, the safety of CPIs in patients with solid tumors and advanced CKD has not been rigorously evaluated. It's just on, right now it's kind of expert opinion based on retrospective review. There haven't really been comprehensive prospective studies, including patients in this category. The incidence and type of irAEs in patients with advanced CKD and ESRD appears to be comparable to those in patients with normal renal function or mild renal impairment, as we see based on our study and also the prior studies that have been done. And we really would like to see more prospective data on this topic, particularly in ESRD patients, also advanced CKD in general. Hopefully, with enough of these retrospective reviews documenting this, we can see prospective trials, including this patient population. And that is all.
Like, share, and subscribe here on Oncology Tube to get notifications when similar videos are available.